So I'm going to talk about MIGS, and I've been given 4 procedures in 7 minutes. So I'll try to run through them, and I'll talk a little bit more about istent. So we have plethora of surgical options, and today I'm going to talk about ab interno surgeries, which are Schlemm canal based. Currently, we know there are limitations of using drops because of compliance issues and ocular surface disorder issues. Other option is laser trabeculoplasty, which can be a good adjuvant to the medical therapy, but we know that the effect of laser trabeculoplasty wears off over time. And then we have conventional surgeries like trabeculectomy and tube shunts, which work great, but I would reserve them more for more advanced glaucomas. So we need some effective procedures for mild to moderate stage of glaucoma. And that's where MIGS comes into the picture. Now, what we are treating is juxtacanalicular meshwork, which is the major site of aqueous outflow resistance. And by doing MIGS, we try to remove this juxtacanalicular meshwork along with the inner wall of Schlemm's canal so that aqueous gets access to the collector channels. Now we have different ab interno Schlemm's canal procedures like ab interno trabeculectomy in the form of trabectome, micro bypass micro stent in the form of istent, then ab interno trabeculotomy in the form of GAT, that is using a proline causing 360-degree fracture in the trabecular meshwork, and then dilatation of the canal using internal approach, that is ab interno canaloplasty. Now, what are the indications for MIGS? I would reserve them primarily for mild to moderate glaucomas. You can do them in phakic as well as pseudophakic patients, but in pseudophakic, visualization of angle is easier. Especially I would use them for patients who are intolerant to medication or those having ocular surface disorders. And we know when patients using more than one drop, a large percentage of them have a lot of blepharitis and ocular surface disorders and positive inflammatory tests. And those patients who are poorly compliant to the medications. One important thing is you have to do gonio before you plan a MIGS and make sure that you're able to see angle structures very clearly so you know exactly where to insert your device. Now the first procedure is trabectome. It's a simple electrocautery device which has got a distant plate which insulates the ocular tissue and it prevents damage to the tissue. And once it cuts through the trabecular meshwork, it also absorbs the material release so that inflammation is controlled. One of the limitations for this procedure is it is quite expensive and disposable probe. This meta-analysis showed that it caused a decent drop in the IOP of almost 31%. And either you do trabectome alone or you combine it with a phaco, and both of them caused a decent reduction in IOP. Only surprising thing I found was in a combined there was a laser IOP drop than a trabectome alone. Generally you expect other way around because doing phaco itself will cause some drop in the IOP, and success rate was pretty decent at 66%. The next procedure is bent ab interno needle goniectomy. This is the most cost-effective way to do it, as you just need a 27 gauge needle, which you bend 90 degrees at the end and just swipe few clock hours of trabecular meshwork, exposing the Schlemm's canal. Now, this is a pretty simple and cost-effective procedure described by Dr. Shebiani. However, I did not find much of a scientific literature on this. This was some study presented in ARVO, which showed that there was a 20% reduction in IOP over 3 months, and almost IOP reduction of 20% was found in almost more than 50% patients. So for the cost of the procedure and simplicity, I think it's a very good procedure to do along with your cataract surgery. Another interesting procedure is GAT, gonio-assisted transluminal trabeculotomy. So basically, you fracture 360-degree trabecular meshwork by passing either the most cost-effective is just taking a 6-0 proline, making the end blunt with a cautery and just passing it around 360 degrees. And once you retrieve the other end, just pull both ends out, so you get a 360-degree fracture. And it worked in all types of glaucoma, pseudoexfoliation, POAG, pigmentary, and a very decent drop in IOP of 58%. Only problem was a post-operative hyphema, which was found in large percentage of patients in first week, almost 68%, but in most of them it resolved over a week. I'm going to talk a little bit more about istent because that is something I started doing 2 months back. And this is a micro device which is made up of titanium. It is MRI compatible and heparin coated so that it doesn't get clogged with the blood easily. And it is the smallest device to be implanted in the human body. Now there are multiple studies, and one of them is this study which studied outcome of istent inject in open angle glaucoma is over 4 years, and you can see there was a 46% IOP reduction, and 95% of the patients were medication free. So that was an excellent result of 46% IOP drop, and almost 95% had IOP of less than 18 millimeters of mercury, and 4 years is a long period. Now this was another study. We studied insertion of 2 eye stents in the same eye against that of travoprost, and you can see that the eye stent group has performed quite well, and the treatment success rate was 77% in eye stent group and 53% in travoprost group. Then this was a meta-analysis for eye stent surgeries, and you can see there was and this was over 60 months, so that was a pretty long period, and you can see consistent 30% reduction in the IOP, and you can see there was a 7 millimeters of mercury mean IOP drop over 60 months. And there was a significant improvement in the ocular surface disorder. You can see that the mean fluorescein, that is TBUT, almost 49% longer time for a tear breakup time. So good improvement in tear breakup time, significantly reduced staining, and there was also reduced hyperemia. So reducing ocular surface disorder is a very important thing, because that is one of the major reasons why patients' compliance is affected. And this is another long study, and the interesting part of this study was it also studied severe open angle glaucomas, and you can see there was almost 6 millimeters of mercury drop over 6 years post-operative. So we know that every millimeter of mercury counts, and 6 millimeters in a advanced glaucoma shows that it is pretty effective. And then comparing istent with istent inject of course was better in reducing intraocular pressure. There was more reduction of drops in a istent inject group, and both groups became medication free. Almost 70% of the eyes in both groups were medication free. So just to describe the technique, now I started practicing on my routine phaco cases almost a month before I planned a surgery, and you should know gonioscopy very well. You need to start practicing this direct gonio. So after end of your every cataract case, you can just learn to rotate patient's head and learn to rotate your microscope. So your microscope should be tilted towards you and patient's head away from you. So you're seeing parallel to the iris directly into the angle. This Glaukos provides this eye prism, which is a good disposable prism, along with the eye stent. And you have to use an excellent viscoelastic also. AIOC makes 1.8% Helon, which works very well. Magnification is the key. So before you actually start inserting the device, you make sure that your position is perfect. You are focused on the trabecular meshwork and use maximum magnification so you know exactly where you are inserting your device. So see, I'm putting some jelly over the cornea to have a good coupling agent for my eye prism. You need a very good visco because you need a strong, a very well-formed anterior chamber. Initially, I tried using the basic one in my first case, and there was some problem. So this is the best. AIOC makes 1.8% and it's good. Now I've gone in. Now you see that there is a red reflux in the trabecular meshwork. At the end of phaco, you generally get this blood reflux in the Schlemm's canal, and that makes identifying Schlemm canals much easier. So you go at an angle, and once you become parallel and just insert that device inside. You can just see that body of the device partially through the trabecular meshwork, and it is basically the feel. After doing 1 or 2 cases, you know that you are exactly in the correct plane. So once you get that feel, your surgery becomes faster, and that's it. It takes very short time to do it. Another thing is you should see some blood reflux coming out after you insert the device, so you are sure that you are in the right place. And when you do, you can see, I'm just showing it again, and you can see that snorkel is facing towards you, and you can see some blood oozing out. So that says that you're in a perfect plane. For the constraint of time, I'm not showing istent inject case, but both the devices are pretty user friendly, and once you get a hang of it, you should not take more than 5 minutes to finish the case. And these are very quick results, but I've just done 9 cases. I'm presenting only 8 because one person was a ENT surgeon, and I had explained her she might not be the great case for it, but she still wanted to try it before I go for a trab, and I'm done. So you can see I did 9 cases, and there was a decent almost 20% reduction in IOP and almost 16% drop in the use medicines, but this is a very small number. These are very early results. So as we do more, we will know exactly how it's working. Thank you.